Hello everyone. In this lecture, we are going to study obsessive compulsive related disorder. In this section, we will take a closer look at the key features, causes, and possible interventions so that we can better understand how these disorders affect daily life and how they can be managed. Before we dive into the details, let's take a look at the contents of this chapter. First, we will start with an overview of what obsessive-compulsive disorders are. Then we move into specific disorders. Now, let's start by defining what obsessive-compulsive disorders. This group of disorders is characterized by repetitive thoughts and behaviors. Individuals often feel compelled to perform certain actions or mental acts in order to reduce anxiety. These disorders share key features such as intrusive obsessive thoughts, repetitive compulsive behaviors, or sometimes both. It is also important to note that in DSM-5, these disorders are classified separately from anxiety disorders, highlighting their distinct characteristics. On the right side of the slide, you can see some of the main disorders in this category. Now, let's move on to obsessive-compulsive disorder, or OCD. Let's take a closer look at the key features of OCD. First, individuals with OCD experience obsessive thoughts. These are recurrent, intrusive, and distressing ideas or images, such as fears of contamination, aggressive impulses, or even disturbing mental images. To cope with these obsessions, they often perform compulsion or rituals. These can include repetitive behaviors like watching and checking, or mental acts like counting or repeating words. The purpose of this compulsion is to reduce distressing or to prevent some dread outcome. For example, someone might wash their hands excessively to neutralize fears of contamination. In terms of course, symptoms may come and go, but if untreated, OCD often become chronic. And regarding the onset, research shows that about 40% of childhood or adolescent cases may remit by early adulthood. Now, let's look at the causes and risk factors of OCD. From a biological perspective, OCD has been linked to abnormality in the brain. One explanation is serotonin dysfunction, where the activity of serotonin is abnormally low in certain brain area. In addition, brain imaging studies show dysfunction in regions like the orbital frontal cortex or caudate nuclei. This overactivity can contribute to intrusive thoughts and repetitive behaviors. From psychodynamic perspective, OCD is thought to arise from unconscious conflict or unacceptable impulses. Defense mechanisms then transform these impulses into obsessions and compulsions. Freud even suggested that Fixation during the anal stage of development could lead to traits such as excessive orderliness, rigidity, and anxiety. Another explanation of OCD comes from learning theory. Conversions are considered learned behavior. According to Morrow's two-factor theory, fear is acquired through classical conditioning, and conversions are reinforced through operant conditioning. For example, washing hands reduces anxiety about contamination, so the behavior is repeated. From a cognitive perspective, trying to suppress intrusive thoughts can actually make them more frequent. This is sometimes called the white bear effect. People with OCD also tend to overestimate their responsibility for these thoughts, and they even believe that simply thinking about an action, such as harming someone, is as bad as doing it. This is called thought-action fusion. For the treatment of OCD, pharmacological interventions are often effective. The most common option is antidepressants, specifically SSRIs, which help by increasing serotonin activity in the brain. In very severe and treatment-resistant cases, neurosurgery or psychosurgery may be considered as a last resort. One of the most effective treatment for OCD is cognitive behavioral therapy. The key component is exposure and response prevention, or ERP, where patients are gradually exposed to anxiety-provoking situations while being prevented from performing compulsions. This helps reduce anxiety over time. In addition, cognitive therapy targets distorted beliefs such as exaggerated responsibility or thought-action fusion. When combined, ERP and cognitive therapy are considered the most effective psychological treatment for OCD. Now let's move on to body dysmorphic disorders, or BDD. In Korea, this is called 신체 변형 장애. Let's take a closer look at the key features of BDD. First, individuals with BDD show excessive preoccupation with minor or even imagined flaws in their appearance. These flaws may not be noticeable to others at all, yet they become a major source of anxiety for the individual. The most common areas of concern include skin, hair, nose, and body shape. Because of this preoccupation, individuals often engage in repetitive behaviors such as frequently checking the mirror, comparing themselves to others, engaging in excessive grooming, or trying to camouflage the perceived defect. These behaviors and thoughts cause severe distress and significant impairment in daily functioning, making it difficult to focus on work, relationships, or social life. Finally, one of the most serious aspects of BDD is high risk of suicidal thoughts and attempts, which highlighted the importance of early detection and effective treatment. Now, let's look at the causes and risk factors of BDD. First, there seems to be genetic link as studies show higher prevalence among relatives of OCD patients. Second, individuals often hold a core belief such as, if I have a flaw in my appearance, then I'm worthless. This distorted belief system reinforces their obsession with looks. Third, social reinforcement also plays a role. Compliment or criticism about physical appearance can actually increase preoccupation with perceived flaws. In addition, early life experiences such as emotional, physical, and sexual abuse, as well as neglected, may contribute to the development of BDD. Finally, cognitive biases are involved. Individuals tend to over-focus on very small or minor details of their face or body, which others might not even notice, but to them it becomes overwhelming. Finally, let's look at the support and intervention for BDD. Medication can be helpful, in particular SSRIs are effective and commonly used, similar to the treatment of OCD. In addition to medication, CBT, considered the most effective psychological intervention. CBT includes several approaches. First, exposure therapy encourages patients to face feared situations such as looking in a mirror or wearing certain clothes. Second, response prevention helps them avoid reassurance seeking or excessive checking behaviors. And overall, CBT aims to help patients correct distorted beliefs about their appearance, reducing preoccupations and distress. Next, we will move on to hoarding disorder. Hoarding disorder is characterized by the persistent difficulty discarding possessions regardless of their actual value. People with this condition feel a strong emotional attachment or responsibility toward their items, which makes letting go extremely difficult. Commonly hoarded items include newspaper, clothes, bags, books, letters, or even documents. Over time, these objects accumulate, creating severe clutter that interferes with daily living and causes significant distress. In addition, hoarding is often associated with traits such as indecisiveness, perfectionism, procrastination, and poor organization. Research also shows that hoarding tends to be more common in women and often begins in middle age, usually after the age of 50. There are several possible causes and risk factors for hoarding disorder. First, temperament play an important role. Individuals with a tendency toward indecisiveness and perfectionism are more vulnerable. Second, environmental factors such as stressful or traumatic life events may trigger the onset or make the symptoms worse. Third, childhood experiences can contribute. For example, a strong attachment to objects such as toys or dolls during childhood may persist into adulthood. Finally, hoarded possessions are often deeply tied with one's sense of identity. For some, discarding items may feel like losing a part of themselves, which makes it extremely difficult to let go. When it comes to treating hoarding disorder, research suggested that a combined treatment of CBT along with medications such as SSRI is often the most effective. From a cognitive approach, therapy helps a patient identify the reason behind their hoarding behavior and challenging distorted beliefs about the value or usefulness of items. On the behavioral side, patients practice discarding unnecessary possessions while also developing stronger decision-making skills to manage daily life. Finally, anxiety management plays a crucial role. Since discarding items often triggers intense anxiety, therapy focuses on helping patients confront and reduce these fears step by step. The next disorder we will discuss is trichotillomania, also known as hair pulling disorder. As the name suggests, this disorder involves repetitive hair pulling behavior, most often from the scalp, eyebrow, or eyelashes. In DSM-4, trichotillomania was classified under impulse control disorders, but in DSM-5, it was reclassified as an obsessive compulsive related disorders. The hallmark feature is recurrent pulling of hair, which leads to noticeable hair loss. The most common area includes the scalp, eyebrow, eyelash, beard, even pubic area. Episode can last from minutes to hours and often persist for months. Individual may also engage in related behaviors such as examining, playing with, or even eating it, the pull hair. Hair pulling is often triggered by anxiety or tension, and the act is usually followed by a sense of relief and satisfaction. This behavior tends to target specific scalp area, creating irregular bird patches. Some may also pull fibers from animals, dolls, or materials like sweater or carpets. Other related repetitive behavior can include skin picking, nail biting, and lip chewing. There is also a strong genetic vulnerability, and the condition is more common among OCD patients and their first-degree relatives. In severe cases, ingesting hair, a behavior called trichoephagia, can cause serious medical complications such as anemia, abnormal pain, intestinal blockage. There are two main perspectives on the causes of trichotillomania. From the psychodynamic perspective, hair pulling may reflect unconscious conflicts and poor object relations. In this view, pulling hair can serve as a way to cope with real or imagined threats of losing an important figure in one's life. From behavioral perspective, trichotillomania is seen as a learned behavior similar to other habits. It often functions as a stress coping mechanism reinforced by the temporary relief of tension, which is an example of negative reinforcement. Over time, hair pulling becomes conditioned to bodily sensations or external triggers, which helps maintain the cycles of the behavior. When it comes to treatment, medication has no clear evidence of effectiveness. Instead, behavioral therapies are more commonly used. These include biofeedback, which helps clients gain awareness of their bodily responses, covert sensitization, where negative imagery is paired with the hair pulling urge, and aversive therapy combined with response prevention, which reduces the likelihood of engaging in the behavior. One of the most effective approaches is habit reversal training, or HRT. This involves three main steps. First, helping patients increase awareness of when and why they are pulling. Second, teaching alternative and safer behaviors to replace hair pulling. And third, ensuring patients maintain motivations and generalize these skills across different situations. Next, let's look at excoriation disorder, also known as skin picking disorder. It is characterized by recurrent picking of the skin, which can lead to noticeable skin lesions, significant distress, and impairment in daily functioning. Excoriation disorder is classified under obsessive compulsive related disorder due to its overlap with OCD and body dysmorphic disorders. The main feature is repetitive picking at one's own skin, which can involve healthy skin, acne, or scabs. Common behavior include scratching, squeezing, digging, or even biting the skin. Episodes may last for hours, and symptoms often persist for months or even years. This leads to skin lesions, which individuals may try to hide with makeup or clothing. After picking, some people may examine, collect, or even ingest the skin. Typically, episodes are triggered by anxiety or tension, and followed by feelings of relief, gratification, or temporary satisfaction. Excoriation disorder was only recent included in DSM-5, so research on effective treatment is somewhat limited. Unfortunately, it is often dismissed as a just bad habit. This lack of recognition can prevent individuals from receiving proper treatment, and the condition may progress chronically, leading to guilt, shame, depression, anxiety, or even co-occurring substance use. One of the most effective approaches is habit reversal training. This involves increasing awareness of the repetitive behavior and then replacing skin picking with harmless alternatives such as applying lotions or squeezing a stress ball. Another approach is acceptance enhanced behavior therapy, which help clients recognize their triggers and practice techniques for preventing responses. Finally, there is comparing response training. When the urge to pick arises, individuals are encouraged to engage in alternative actions such as clenching their fist, playing with objects, leading, or using another distracting behaviors. In this section, we explored various types of obsessive compulsive related disorders. I hope this gave you a clear understanding of obsessive compulsive related disorders. Thank you for your time and attention.